From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Welcome to this JAMA Author Interview podcast. I'm Dr. Phil Fontanarosa, Interim Editor-in-Chief of JAMA, and we are pleased to have this discussion today with authors of articles in the August 17th issue of JAMA. This issue of JAMA includes a collection of research and opinion articles on the topics of racial and ethnic disparities and inequities in medicine and health, written by authoritative authors, including those with us today. The moderator for this podcast is Dr. Ebony Boulware. Dr. Boulware is Professor of Medicine, Chief of the Division of General Internal Medicine in the Department of Medicine, Vice Dean for Translational Science, and Associate Vice Chancellor for Research in the School of Medicine at Duke University. Dr. Boulware is a member of the JAMA editorial board and also authored a viewpoint in this issue of JAMA. Joining us for the discussion today are three other distinguished viewpoint authors: Dr. Francisco Cigarroa, Dr. Howard Koh, and Dr. David Satcher. Dr. Cigarroa is Professor and Director of the Transplant Center at the University of Texas Health Science Center at San Antonio, the Carlos and Malu Alvarez Distinguished University Chair, and holds the Ashbel Smith Professorship in Surgery. From 2000 to 2009, Dr. Cigarroa served as President of the University of Texas Health Science Center in San Antonio. From 2009 to 2015, he served as Chancellor for the University of Texas System. Dr. Cigarroa is a member of the JAMA editorial board as well. Dr. Howard Koh is the Harvey V. Feinberg Professor of the Practice of Public Health Leadership at the Harvard T.H. Chan School of Public Health and the Harvard Kennedy School. He is also co-chair of the Harvard Advanced Leadership Initiative and director of the Leading Change Studio at the Harvard T.H. Chan School of Public Health. From 2009 to 2014, Dr. Koh served as the 14th Assistant Secretary for Health for the U.S. Department of Health and Human Services. Dr. Koh also is a member of the JAMA editorial board. Dr. David Satcher is the founding director and senior advisor at the Satcher Health Leadership Institute at Morehouse School of Medicine. From 1993 to 1998, Dr. Satcher served as director of the Centers for Disease Control and Prevention. From 1998 to 2002, Dr. Satcher served as the 16th Surgeon General of the United States and also served as the 11th Assistant Secretary for Health for the U.S. Department of Health and Human Services. Dr. Cigarroa, Dr. Koh, and Dr. Satcher, thank you so much for joining us. And Dr. Boulware, thank you for serving as moderator for this podcast.
Hi, Dr. Cigarroa, Koh, and Satcher. First, I'd like to thank you for taking time to create a space for this very important conversation about race and ethnicity and how they impact our communities, the health of individuals within our communities, and our clinical practice. Each of you has written a very powerful piece about the experiences of specific racial and ethnic groups, some of the health inequities they're experiencing, and how these experiences and inequities relate to clinical care and the medical profession. I'd like to open up our dialogue to ask you each about why this is important to us in medicine. Could you each speak from your own perspectives, particularly about the diverse groups that you've written about, why this is an important conversation for us to have right now? Starting with Dr. Koh, why is this important to have right now with regard to individuals who've been categorized as Asian American, Native Hawaiian, and Pacific Islander?
So first and foremost, Dr. Boulware, thanks so much for moderating, and I'm delighted to join my dear friends, Dr. Satcher and Dr. Cigarroa, on this very important panel. And this is a really critical time for our nation to look at the disparities and health equity issues for Asian Americans, Native Hawaiians, and Pacific Islanders. I'll use the acronym AANHPI for short. Through COVID-19, we've seen a long simmering history of prejudice against Americans of Asian descent, now starting to boil over in a spate of hate. We've all witnessed this on the media. And through a pandemic that's exposed widespread health inequities, it's particularly triggered this rhetoric blaming COVID-19 on the AA and HPI community. So I'm Asian American, I'm Korean American. These are issues that I've thought about my whole career as a physician and as a public health professional. Our community is the fastest growing racial ethnic group in the US, but it's still poorly understood. Most times it's quite invisible, quite honestly. But then in times like this, we need to understand why this hate has erupted, why the AA and HPI population is too often viewed as foreigners in our own country and as outsiders. Try to understand what's behind these assaults. Try to put this in the context of broader health disparities that have been slowly described over a number of years, and then try to address all these issues as a country that's becoming increasingly diverse. I know Dr. Boulware through this broadcast will talk about many of the dimensions. One major part is that the AA and HPI population is not monolithic. We are profoundly heterogeneous. It's a community that is linked to some 100 languages and 50 ethnicities and some 19 countries. About 2/3 of our community is non-US born. About a third have low English proficiency. So there are multiple challenges here, and disaggregating the information, being more focused and granular about understanding the diversity of this population, putting a brighter light on disparities and health equity is going to be really critical for the future of this country. As I end my opening comments, I just want to say that as an Asian American physician, when I was young, much younger, I looked for data on these issues and I couldn't find any. Often the response back to me was, there is a lack of data. Fortunately, over time, we're getting more and more information, but not enough. And so I'm hoping these issues of data and research and dedicated understanding of disparities and health equity strategies for the future will be very, very important for our listeners.
Thank you so much. Dr. Sigaroa, could you follow on with why is this an important discussion to have right now with regard to individuals who've been categorized as Latino or Latinx?
Absolutely. Again, just as Howard stated, very grateful to be on this panel. As Howard stated, COVID certainly put a spotlight on healthcare inequalities. And the spotlight actually demonstrates that, in fact, these issues have existed long before COVID. When I was asked by Phil to write a viewpoint, I was a bit saddened as I looked at the statistics of medical student and nursing student enrollment. When I was president of the Health Science Center and overlooking the medical school, we spoke about the importance of diversity. And we saw that essentially Hispanic students, in large part, only included 6% of medical student matriculants. And 20 years later, those statistics have not really improved to any significant degree. And so when you take a look at the nation's younger population today, those who are 16 years of age or younger, over half of them identify themselves as racial or ethnic minority. And so the changing demographics demand our society to embrace diversity, equity, and inclusiveness, really as our responsibility to better navigate the future, as our responsibility to better improve the social determinants of health, and in our responsibility to assure that our nation is not only healthy, but also in regards to our economic success as a nation and our security. So it is absolutely incumbent upon us to significantly improve the issues of diversity, equality, inclusiveness in every aspect of our lives in our nation.
Thank you. Dr. Satcher, following with you, why is this important to have a discussion about this for individuals who have been categorized as African American or Black?
Well, thank you for allowing me to participate in this outstanding panel. Something tells me I'm a little older than the rest of you. But anyway, I grew up in Anniston, Alabama, during a time of really strict segregation. I recently wrote about an initial experience that I had when I had saved money to go buy an ice cream cone, and only to discover that in that particular case, they didn't sell ice cream to African Americans. So we've come a long ways from there, of course. I also was a student at Morehouse in Atlanta during the time of the student movement. So I became quite involved in the student movement, rose to a leadership role in that movement, went to jail, went to prison. And so medicine for me has been very important. And I've tried to respond to the challenges of race and racial inequity in health care throughout my career. Let me just say that I think we've come a long ways in a lot of ways in terms of medicine and medical practice, and yet we still face significant challenges. And when I wrote the article 50 years ago about race and the doctor-patient relationship, it was a different time, but some of the same problems still exist. Clearly, we've made some progress, and yet we still have a long ways to go in terms of dealing with these issues. We talk a lot about the disparities, and I think it was in 2000 when I was responsible for providing leadership for releasing Healthy People 2010. And there were only two goals in Healthy People 2010. One was to improve the quality of life for people as they aged. And the second one was to eliminate disparities in health. And so there has been sort of a continuing struggle in this area. And that struggle continues today as we deal with COVID-19. And I've been asked why it is that there are disparities in COVID-19 and how it impacts different populations. There's an interesting correlation between disparities in health and predispositions for COVID-19. In other words, if there are disparities in heart disease, hypertension, diabetes, etc., those same disparities predispose individuals and groups to COVID-19. And that's what we've seen, I think, in this pandemic, differences in predispositions to COVID-19 that correlate with disparities in health.
Thank you so much. I think you've each brought out why this is such an important dialogue to have right now. As I read through all of your pieces, I feel that there's several common threads, and I want to start off with the common thread of historically marginalized groups of individuals being invisible with respect to their health experiences and their health care. And each of you provide a historical context to that in your pieces. And I want to ask you each, starting with Dr. Satcher, how have societal or structural racism, and by that I mean the policies and practices that occur at the societal level to contribute to this, how have they played a role in generating that invisibility of these historically marginalized groups of individuals? Dr. Satcher?
Well, I'm not so sure that I would agree about the invisibility, but let me just say that in the case of African Americans, there's a long history here. I mean, like 400 years. And so that history sort of has moved to different stages of our relationships, from slavery to segregation. I grew up in a period of strict segregation in the South, and I grew up in Alabama, one of the most segregated places at the time. And I think the transition for me, of course, was college. It was Morehouse and the Atlanta University Center. It was the student movement and the opportunity to, for the first time, really, to sort of fight back and to confront racism, I guess I would say. So the idea of confronting racism is something that I didn't experience in Alabama as much as I experienced when I became a student at Morehouse College in Atlanta. So I think I've tried to continue that tendency to confront racism as opposed to just experience it. And the whole issue of race and the doctor-patient relationship was my attempt to confront not just racism, but how race impacts the doctor-patient relationship.
Thanks. And when I say invisible, it's sort of how does it show up in that doctor-patient relationship? Traditionally, has it shown up for Black individuals in the context of us thinking about our connections with our patients? In your thoughts?
I think when I wrote the article in 1973, I tried to describe how race impacted the doctor-patient relationship. I can just give you some examples. My first patient, and this was in Cleveland at Case Western, my first patient happened to be from Mississippi. And I did like every other diligent student. I did a thorough workup. And the next day, of course, this patient checked out of the hospital. He was from Mississippi. And the idea of having a Black doctor didn't set well with him. But it was not new to me. I should say that. Being from the South prepared me for those kinds of experiences. And I tell the story later on, of course. That patient's family contacted me and when I was Surgeon General and said that he wanted me to know how proud he was of me for being Surgeon General. And his daughter wanted to know if I could forgive him for what he did. And I told her that I forgave him a long time ago because, as a physician, I think my responsibility is to understand the shortcomings of patients, whether it's in their health or their attitudes, and to try to deal with it.
Wow, very powerful. Thank you. Dr. Coe, how would you place this concept of invisibility with regard to the AANHPI community or communities?
Well, thank you. And maybe I should start by saying I had the great honor of succeeding Dr. Satcher as Assistant Secretary for Health in 2009 through 2014, and also had the honor of unveiling Healthy People 2020. And now there's a Healthy People 2030, of course. So with each successive iteration of Healthy People, there's more attention to diversity, to health equity, to social determinants of health. So that makes these issues more and more visible. But for the AANHPI community, usually you don't hear much about our community's issues regarding health or having anything to do with daily societal life in the US until years like last year. You all know, for example, that the most dramatic example of these hate incidents was the shooting of 8 people in Atlanta in March of this year, which included 6 women of Asian descent. And then in tracking these hate crimes, which is done through some of my great colleagues in California, there has been explicit documentation of xenophobic slurs that are uttered through these assaults that are verbal or physical. So when an American of Asian descent is hearing slurs like, "You brought the virus here," and "Go back to where you came from," what do you do if where you are from is the United States of America? And I'm a son of a very proud Korean American family. So these are issues I've thought about every day of my life. But most times in the professional setting, we don't get to talk about it too much. So through this crisis, there is an opportunity for the AANHPI community because our numbers are growing. We are contributing more to the American social and political scene on a daily basis. So I think the more education we do about the heterogeneity of our group right now is very, very important. And this spills into healthcare, of course. Some 20% of US physicians are of AANHPI background, and they are not exempt from the discrimination and hatred that's going on right now. There was a very well-publicized incident of an Asian American medical student in New York who was going to the hospital and work and was subjected to physical assaults. And so she's mobilized that community in a very powerful way there. She is somebody that we admire very, very much. If I can say also within the healthcare community, I think this is an opportunity for every healthcare professional, physician, nurse, or otherwise, to just examine their own biases toward patients of Asian American, Native Hawaiian, and Pacific Islander background. I say in our viewpoint, which I had the pleasure of co-authoring with Juliet Choi and Jeff Caballero, that if we do nothing else, clinicians should try to identify their own biases and assumptions about any patient of Asian American, Native Hawaiian, Pacific Islander background. Don't assume their ethnicity, their birthplace, their first language, their culture, their spouse, their sexual orientation, or worldview. Don't assume anything. Just ask and listen. That's what true patient-centered care is all about. And if we have a little more time, I can say that on a national scene, we're seeing some leadership from the president about addressing Asian American hate and activating his White House initiative on Asian Americans and Pacific Islanders to try to do this in a more integrated function nationwide.
Thank you. Dr. Figueroa, can you comment about the visibility or lack thereof of these inequities with regard to the Hispanic, Latino, Latinx community?
Well, as I did the research on the Viewpoint in regards to national media related to COVID, only 2% of all national media related to Hispanics and their risks of developing COVID. So even from a social media perspective, pretty anemic. I actually had a difficult time whether selecting invisibility or lack of presence as an emphasis point in the Viewpoint. And at the end of the day, I decided to focus on lack of presence because there have been so many of our ancestors and individuals who have been quite visible and have been, advancing the cause. But you also spoke about structural issues that result in a lack of presence or invisibility, not only for Hispanics, but for other underrepresented minorities. And a couple of structural issues come to mind that actually impact all of us today. For example, you have a first generation student, often who are underrepresented minorities in college, and perhaps are interested in pursuing a field in medicine or science. And a lot of times that requires summer programs. And many summer programs these days aren't paying for a variety of reasons. And so an individual who actually has to work during the summer to support themselves in college the following year are sometimes left out of these really important summer programs that can actually be advantageous in the acceptance process in medical school. The second issue is, are admissions committees really taking a look at students in a holistic way? And what have they actually accomplished in their 3 years prior to their application versus strictly an MCAT score? And so admissions committees really need to take a look at an individual in a holistic way. If that hadn't been the case for me, I would not have gotten into medical school. The third issue is tenure policies are changing. Less and less medical schools are actually implementing tenure. And so this also results in a sense of disparities among underrepresented minorities. And so I did mention in the article about how important it is to actually hold boards of trustees and regents also accountable to make certain that their leaders of their academic health centers understand the importance of diversity, inclusiveness, and equality. So again, when I was being considered for president of the UT Health Science Center in San Antonio, the first search committee that came about actually did not have a single member or candidate who was either a woman or an individual of underrepresented minority background. And there was a single regent who stepped up and stated, "This is unacceptable." And leaders at the time told the regent there aren't any qualified candidates who are of underrepresented minority. Well, that one regent didn't find that argument acceptable and actually challenged the system to identify somebody who was also of an underrepresented background to be at least interviewed. Well, if it wasn't for that one regent who actually called the call, I would actually not be having this conversation with you today. So it's so important for governing boards to hold their leadership accountable if we're really going to solve this problem.
Thank you for that. It actually leads right into a discussion I wanted to pull you into with Dr. Satcher in particular around the lack of diversity in our workforce. And in the light of what's happening with the COVID-19 pandemic, with the health inequities, the profound health inequities that we're seeing, start with Dr. Satcher. Can you talk about why it's important that we have a diverse healthcare workforce and how that impacts the patient-physician relationship. And then ask you the same, Dr. Figueroa, just to pull that in with your comments. So Dr. Satcher, can you talk about that in light of what's currently happening in COVID-19? Why is it important that we have a more diverse healthcare workforce?
Well, I think there are a few reasons. I could start with medical school and say that I think physicians in training need to have interactions with a diverse student body. That's the first thing. Because I think by interacting with a diverse group of people, I know my experience was that way, you educate each other and you don't see patients as just patients, but as human beings, like your classmate or what have you. And so that's an important point, I think, to make is that the diversity that we experience cannot just be doctor patient, it has to be also doctor doctor. And I've gained a lot from that kind of interaction. For example, getting to know a person like Howard Coe, it makes a difference in terms of how you approach life and how you approach patients. And so I think diversity is important. But also, I think in terms of understanding something like COVID-19 and asking the question, why is there such diversity in the experience with this virus and outcome? And in great part because there's diversity in health and this diversity in terms of what we call disparities in health. And understanding that disparity helps us to understand a disease like COVID-19 or even violence as far as that goes. I was Howard's discussion of the violence that took place here in Atlanta, in terms of the murders, just so dramatic and just sort of paints the picture of what we're struggling with as a nation, and especially in a place like Atlanta. We've got to stay on this problem. We can't just read about it. We've got to see our role in it. And I think the doctor-patient relationship has to reflect our understanding and our caring. Here at the Satcher Health Leadership Institute, we say that there are 4 components of leadership that are critical. One is, you have to care enough to really provide the kind of leadership that's needed. Secondly, you need to know enough. Thirdly, you need to have the courage to do enough. And I think those of us in medicine, we have something to do, and we have to have the courage to do that. And finally, we must persevere until the job is done.
Thank you so much. Dr. Figueroa, would you like to add to that about the importance of a diverse workforce when it comes to, in particularly times like this, COVID-19, where we're seeing such profound health disparities and health inequities?
Well, it's critically important, Dr. Bowler. First of all, I believe that having the medical school classes reflect only 6% Hispanic enrollees and 4% Black enrollees is clearly unacceptable. And that needs to change. The second thing is that, as Dr. Satcher stated, having a diverse medical student body and healthcare workforce, beyond physicians, really provides a trust factor for many patients, especially in that patient-physician relationship. Understanding backgrounds of underrepresented minorities actually allows you to have a better handle on improving social determinants of health. And social determinants of health often predict, whether patients have access to healthcare and at least understanding what the challenges are, for those patients. For example, we also have, as we stated, unconscious biases. A clear example would be, and this has been written about, that underrepresented minorities are less likely to be a living donor for a patient in need of a transplant. Well, I believe that at the Health Science Center of San Antonio, we've disproven that. Our patient population is over 75% Hispanic, and yet we have one of the largest living donor liver transplant programs, of which the large majority are Hispanic living donors. And I believe that's been made possible by really helping address some of the challenges that our community has, which is really focused on social determinants of health, really providing better financial support for somebody who wants to be a living donor, providing better access to the transplant center. And so if you don't have healthcare providers really understanding the challenges that various populations have, it's pretty hard to actually advance important aspects in medicine. And so for all those reasons, I really believe diversity is critically important to preserve the health and well-being of our nation.
Thanks so much. Dr. Koh, I'd like to turn to you. And you specifically in your piece talk about the importance of asking patients about discrimination, social isolation, or things like financial hardships as a way that physicians and other healthcare professionals can signal their support. This again seems to speak to the quality of the care that we deliver and the patient-physician relationship. I'd like to ask you, what do you think our current state of cultural competency is with care, and what needs to be done to improve it with this regard?
Thank you, Dr. Bilboy. That's a great question. So here's where I think the invisible theme, unfortunately, arises. If you're a clinician and you have a patient who is of Asian American, Native Hawaiian, Pacific Islander background, that's something you sort of note but don't really address. And in a time like this, can I assure you, every member of our community is thinking about these issues and hoping that we can get beyond it and get to a better place in the context of COVID. So if a clinician simply asks about discrimination and acknowledges that that might be complicating that person's quality of life and health right now, that's a big signal. And that could take literally under a minute and be a starter for conversation. And it would really signal a sense of commitment to the patient from the clinician that he or she cares about them as a unique individual. We talk about this term patient-centered care all the time. And I think for patients of Asian American, Native Hawaiian, Pacific Islander background, that's one way to start that conversation. In our piece, we mentioned that the AA and HPI community is sometimes included in diversity, equity, inclusion efforts in hospitals and medical centers, but sometimes not. People often point out that we are well represented among not just doctors, but nurses. But the leadership in our community in medical centers is actually still quite low. And so clinicians hopefully can have more visible leaders that look like them. Patients can have more clinicians that look like them and understand them. And I think all of us, regardless of our background, can recognize how profoundly heterogeneous the AA and HPI community is, commit to overcoming implicit biases, and giving everybody true patient-centered care.
Thank you. A couple last questions I have for the group. First, I'd like to ask Dr. Satcher. You write very powerfully about how current political, legislative, regulatory, and legal systems fuel and perpetuate the health inequities that we're seeing. Could you elaborate on that a little bit and then help us consider how, as physicians and healthcare professionals, we might act as agents to begin to change these systems?
Well, my colleague, Daniel Dawes, recently published a book on the political determinants of health. And I guess about 10 years earlier, I was a part of a group that wrote a report on the social determinants of health. But what is very clear is that health outcomes are not just dependent on medical care. They are dependent on the political environment. They are dependent upon social environment, and when one is born, the extent to which one is poor and where one might be on this social level. But by the same token, as John Lewis often pointed out, politics in many ways impact upon how we relate to each other and therefore how we treat each other. And that includes health care. That includes health outcomes. And to what extent are we managing the factors that determine whether or not we're healthy? And this is something that, we've got to continue to work on in terms of health outcomes. And it's not just COVID-19, but all health outcomes. The life expectancy for African Americans is expected to decrease by 3.3 years, for Hispanics by more than 3.6 years. And these outcomes are obviously related to the pandemic, but they're also related to our general socioeconomic status and interactions.
So, in light of that and those comments, I'd like to ask each of the three of you to just tell us, what do you think some of the most important steps for us to move forward as a field in medicine are? How are we going to ensure that the current and next generations of physicians and other healthcare professionals are operating in a different way? And how will we know that we've made a difference? So I'll start off with you, Dr. Cigaroa. Any thoughts on that?
Yes, well, I think it's first important for leaders in every sector of society to understand the lack of presence of very important individuals reflecting our underrepresented minorities in this nation. And so it does behoove us for, our academic health centers to really become more innovative and more progressive in enhancing the diversity of their classes. It behooves us to definitely identify talented individuals of underrepresented backgrounds to lead our hospital systems and our academic health centers. They are out there and they need to be given the chance. I believe that even in corporate America, to look at the Fortune 500 companies and to see that less than 4% of their trustee independent director positions are those of underrepresented minorities, how can we actually address important economic decisions that would actually improve our nation? How can we actually make certain that pharma is addressing important healthcare issues that affect underrepresented minorities? How can we actually be in positions of leadership to actually tilt social determinants of health to a better place? And so there's still a lot of work to be done, but we can't just say this is for others to solve. We need to solve it beginning now.
Thank you. Dr. Coe, any thoughts, final thoughts?
Sure. First of all, Dr. Boulware, thank you again for moderating this wonderful panel. I want to conclude by saying, as challenging as these inequities are, we can make progress if we work together. And I have some experience in that I'm so proud to share. When I was Assistant Secretary starting in 2009, not only did I serve through the last pandemic, the H1N1 pandemic, and we tried to guide the nation through that. But then, of course, the following year, the Affordable Care Act was passed in 2010, and so much activity in that regard ever since. One major advance through the ACA, through something called Section 4302, was the requirement that all federally funded health surveys of self-reported information collect disaggregated granular data for Asian Americans. That includes Chinese, Indian, Filipino, Vietnamese, Korean, and Japanese, and Pacific Islanders. That includes Native Hawaiian, Guamanian, Samoan, and others. So that was progress. And since then, we're seeing much more dedicated research in this area that identifies specific disparities affecting subgroups and then trying to address them. So one major example I have that I'm so proud to share is that, our administration worked so hard on establishing the Affordable Care Act under Secretary Sebelius and President Obama, and trying to advance health insurance coverage issues. And disparities are part of that discussion, of course. I worked hard on that in DC, and I'll never forget a couple of years ago when I came back to Harvard, my graduate student came to me and we had done a quick literature review and said, Dr. Coe, there's never been an analysis of health insurance coverage disparities affecting Asian Americans, Native Hawaiians, and Pacific Islanders. And I said, what? Can that be true? And so we double checked, and yet again, this was an example of how our community was overlooked. So we embarked on that, and subsequently we published in JAMA Internal Medicine the first analysis showing that the health insurance coverage gap between Asian Americans, Native Hawaiians, and Pacific Islanders and non-Hispanic whites essentially disappeared as of 2016. And that was a reflection, if I can say, of incredible national cooperation with advocates, with community-based organizations. We saw a rise in health insurance coverage for our community overall, but also with respect to the many subgroups. So this can be done. There were lots of advocates doing outreach in multiple languages and respecting different cultures. So if we can recognize that as just one example of how we can address the health equity challenges of our increasingly diverse nation, that would be one I think we should look at as a great example as we move forward. Maybe my final comment here is we also admire Reverend Martin Luther King. He is somebody who has inspired me through my career. And he used to say that he wanted all people to enjoy what he called the sunlight of opportunity. I love that phrase. Some of us have that privilege and others don't. And then he also said, quote, "We may have all come over on different ships, but we're in the same boat now," unquote. I mention that saying of his often. I think that's where we are right now in our country.
Yes.
Thank you. Dr. Satcher?
Well, first, let me agree with Howard. I think that's a very important point in terms of where we are now and how we move forward together. And I think we probably need to have more discussions like this across racial and ethnic boundaries to really appreciate both the challenges and the opportunities that we face. The Affordable Care Act, I just want to add how important it was also to access to mental health care. In a lot of states, it dramatically improved access to mental health care. There are still some states, of course, who have not responded to that tremendous opportunity, but we're making great progress there. And the Affordable Care Act has had a lot to do with that.
Ebony, Francisco, if I could just follow up on what David Satcher stated regarding mental health. That's another, really important aspect of providing cultural competent healthcare. And, having a diverse healthcare workforce can also help us better address many of the mental health issues that our population is facing.
Yes.
Thank you. Well, I'd just like to close this session by thanking each of you for your roles as national leaders in this area to really advance the purpose of improving health equity, and also for this wonderful discussion where you provided wonderful insights and pointed us in the right direction for the future. Thanks so much.
You've been an outstanding moderator.
Wonderful job. Thank you.
Thank you.
Agreed.
Thanks to all of you, Dr. Satcher, Dr. Coe, and Dr. Cigarroa, for sharing your powerful comments and compelling perspectives about these critically important issues affecting medicine and society. And thanks to Dr. Boulware for serving as moderator and so expertly facilitating this wonderful discussion. This episode was co-produced by Jesse McWhorters and Lisa Harden. The audio team at JAMA includes Daniel Morrow and Shelley Steffens. Dr. Michael Berkowitz is the deputy editor for electronic media. I'm Dr. Phil Fontanarosa, interim editor-in-chief of JAMA and the JAMA Network. For more podcasts, please visit jamanetworkaudio.com. Thank you all for listening.